Assalamu alaikum. I hope you're all doing fine. I am Dr. Muhammad Ali Rabbani and I will be guiding you through the questions that have appeared in the August and November attempt of FCPS Part 1 for the topics of lower limb. So we will go from osteology, then from gluteal region, hip joint, thigh, knee, popliteal fossa, leg, ankle, foot, and back to the superficial supply. So for each of the question, I will be discussing with you the question itself, the answer, the reason behind the correct answer, and in my videos, you will find the references to the questions in which exam did they actually appear. If a question appeared in more than one video, in more than one exam, I have added that to the video also. If you have any questions, please let me know in the comments. And if you want to attempt these questions, please feel free to use our free resource, that is MedEd application. I will go into the detail by the end of the video if you want to see that. Let us talk about osteology. Hip bone. At what age do the ischiopubic rami usually fuse, typically fuse? This is a purely recall based question, and here is a picture that gives you the answer. The ischiopubic ramus usually fuse at the end of second year, and it is shown right here in this is a picture from BD Churasia. It shows at 7 to 8 years of age. Bone marrow biopsy is typically performed at which of the following sites? Again, a very commonly asked question. Now notice that in the question you have not been given the age of the person. Whenever you are not given an age of a person, you will assume that that person is an adult if the age is not given. So in adults, the good place to take the sample is iliac crest. If you can palpate on your lateral aspect of your torso, at the lower end you will find iliac crest. You can palpate them as they are just lying beneath the skin. So it's on the very superficial structure, and it has a bone marrow till very advanced age. So that is the correct answer, ventral iliac crest. By the way, here you also should keep in mind that when talking about children, then tibia would have been a better answer. The long bone tibia, the medial aspect of the long bone of the tibia, is accessible for the injection, for the biopsy, and it contains the bone marrow. As the person ages, the bone marrow in the long bone vanishes. So that is why iliac crest preferably, and then in the second option sternum would be a good option, but again due to the proximity of the heart, iliac crest will be preferred here. The floor of the acetabular fossa is formed by which of the following bones? It's a very simple question, as the hip bone is made up of three bones, the ilium, the pubis and ischium. These three bones, they join together to form the floor of the acetabular fossa. Identify the muscle that is connected to the lesser trochanter of femur. For this question, you need to know the attachments of the hip bone and the femur, and in this case femur, you have been given the options of gluteus maximus, minimus, medius and iliopsoas. Here, as you can see in this picture, this lesser trochanter gives attachment to the iliopsoas. Gluteus medius and minimus are attached to the greater trochanter. It is shown here, gluteus minimus and gluteus medius on the lateral aspect, and the gluteus maximus is attached on the posterior aspect. There is a tubercle, the quadrate tubercle, that gives attachment to it. During antenatal period, which of the following bone exhibits an ossification center? Now that's an interesting point. So because most of the secondary ossification centers, they appear after birth. The distal end of the femur is the one that is known for its hurry to appear. So distal end of the femur, the secondary ossification at the lower end, it appears by 8th or 9th month of intrauterine life. For all of the others, primary ossification center usually appear in the second month of intrauterine life. For the rest, they appear after the birth. You see, this is appearing the first year, this is appearing the 12th year, this is appearing in the for the femur and tibia, these are appearing after. But around the knee joint, the one that is at the lower end of femur and the one that is at the upper end of tibia. They have been appearing just before the birth in the 9th month. And this question has been asked quite frequently in the August as well as the November attempt in various specialities. In adults, the injury to the neck of femur is most likely to damage which artery? For that, you need to know the arterial supply of the head of femur to the neck of femur, and the correct answer is medial circumflex femoral artery. As you can very well see in this picture, the head of the femur, again, the adults, the age is given. In adults, the all of this supply is through the neck, and it is being supplied by the trochanteric and cruciate anastomosis. And the most prominent artery, that is going to supply is this medial circumflex femoral artery, and it is supplemented by lateral circumflex femoral artery on the back. So if you are given the options of medial and lateral circumflex femoral, you will opt that one. If you are asked to pick one of the two arteries, you will pick the bigger artery, that is medial circumflex femoral artery. And in case of any fracture right here, this artery will break. So this question can be asked in a variety of ways. For example, in context of hip surgery, if the artery supplying the head of femur is occluded, again we are talking about the medial circumflex femoral artery. What is the primary artery that supplies this vessel? It is itself a branch of profunda femoral artery, and profunda femoral artery, it's a branch of femoral artery. So let's see what options have we been given. There is no option for profunda femoral artery, so we'll pick out the next best, that is the femoral artery. As you can see, that is the profunda femoral artery, this one. Medial circumflex femoral artery is a branch of profunda femoral artery, and that in turn is the profunda femoral artery. Let me be more specific. This one is the profunda femoral artery, and this is a branch, and this is the femoral artery. So if both are given, the better answer would have been profunda femoral, but as it has not been mentioned here, you can very well opt for the femoral artery. A patient presents with avascular necrosis of head of femur. See how many times it has been repeated in the November 2023 attempt. Which artery is most likely involved? In the case of adults, the medial circumflex femoral artery is the chief supply, or the trochanteric anastomosis, or a combination of medial and lateral circumflex femoral arteries. So when they break, when the neck of femur fractures here, this area stops receiving its blood from this pathway, so it goes into avascular necrosis. But keep in mind, in young children, this has an additional supply of acetabular artery coming from the artery in the ligament of head of femur, and that artery in youngs, that artery, it's a branch of, that artery is called acetabular artery, and it is a branch of obturator artery, and that artery is branch of internal iliac artery. Usually you are asked a question regarding the adults, because in adults this fracture is very common, but if you are given a question about a young person, it has an additional supply of acetabular artery. So in children, the neck of femur fracture does not result in avascular necrosis. An elderly patient presents with shortened, externally rotated leg after a fall. Which of the following fracture is most likely? So that is due to neck of femur. Even if you are asked which fracture is most likely, you will go for neck of femur. And after the neck of femur fracture occurs due to the long muscles like the hamstrings in the back and rectus in the front, the femur is pulled up, so the overall height of the leg, if you take it from bony landmarks, if you take it from any bony landmarks, it becomes short as compared to the normal leg, because of this defect, this displacement that has occurred, upward displacement. Moreover, the unopposed action of the adductors muscles, chiefly adductor magnus, and the other muscles of the medial compartment of thigh, along with obturator muscle, that lead to the lateral rotation of the thigh. So a person with a neck of femur fracture will be presenting to you with shortened length of leg and externally rotated. During orthopedic surgery, which fracture type is likely linked most commonly linked to the elderly population? Simply, if you are asked regarding the statistics, you will go for the neck of the femur fracture, because in elderly, after osteoporosis, this area is very vulnerable as it is transmitting a lot of force and it is a very at awkward angle, so this fractures commonly. In infants, bone marrow biopsy is most commonly performed at, as we saw that in adults, ischial spine, iliac spine, and sternum are the preferred site. But in children, as the long bones contain the bone marrow, so we can go ahead for bone marrow biopsy in the tibia. That question has been frequently asked again. And here is a picture from embryology. You can see as the person is born, in the early time, all of the bones have the bone marrow and they produce bone marrow. So tibia and all the long bones have the bone marrow that can be aspirated. But as you can see, as the person ages, the long bones, the tibia, the femur, the radius ulna, they sharply drop the content of the bone marrow in them. It is replaced by the fatty tissue. So if a person becomes adult after 20 years, you can see if you penetrate tibia, you will find nothing there. So the better answer would be one of these bones. The bones that are irregular, as you can see, the vertebra column and the pelvis is having the most amount of bone marrow. So iliac crest, due to its proximity to the skin, will be a very good option. And secondarily, it is not it's not in the approximation to any vital organ, as opposed to the sternum, because in sternum, if you go through and through the sternum, you are going to penetrate the heart, so that is not very much preferred for that reason. Regarding fibula, a common question asked, or I would say most common question asked, is regarding common peroneal nerve. At which point the injury to the common peroneal nerve can occur at which location? It usually occurs near the neck of the fibula. During its pathway from the exiting the popliteal fossa, it winds around the head of the fibula, neck of the fibula to be more specific. And if the neck of the fibula gets damaged or fractured, this nerve, due to its proximity, gets involved and damages. And as you can see very well here, it is going to supply the lateral compartment through its superficial branch and anterior compartment through its deep branch. We will go through them further in the next questions. A patient involved in the road traffic accident sustains a fracture of the neck of the fibula. Again, that is the injury of common peroneal nerve. The patient is unable to evert and dorsiflex the foot. Now, this is an additional hint that it has been given to you. Which nerve is most likely damaged? The common peroneal nerve is damaged, and in addition to that, you are given the clues of the movement. The lateral compartment is chiefly responsible for eversion of the foot. Eversion is the movement which leads to raising of the lateral margin of the foot, and the anterior compartment leads to this dorsiflexion of the foot, that is you standing on your heels with your toes pointing up. So these are the movements that are lost. In addition to that, you may be asked that the sensation has been lost on the dorsal aspect of the foot. If separately asked about the deep branch, then the deep branch supplies this cleft between the first two metatarsals, and when talking about the superficial branch, it supplies all of the dorsum except this cleft, but usually you are asked about the whole of the common peroneal nerve that includes all of the dorsum of the foot. Which part of fibula is most commonly used for bone grafting? For bone grafting, the middle part, the middle third is usually used as it has its own vascular axis. You can take it out with its own arteries and veins that can be grafted, and arteries can be anastomosis, vessels can be anastomosed at the graft site. Let us move to the next topic, that is the gluteal region. In the gluteal region, which structure are transmitted through greater sciatic foramen? So this is one of the very commonly asked questions. For the purpose of solving this question, you need to be very confident regarding all of the structures that are passing in the greater sciatic foramen through the lesser sciatic foramen, and even within the greater sciatic foramen above or below the piriformis. That question has always been a part and parcel of this exam. So among these options, the piriformis is the right answer. Femoral nerve is anterior of the thigh. It runs through femoral triangle below the inguinal canal. Obturatus internus passes through less sciatic foramen. Pudendal nerve, technically speaking, that is a right answer too. It is passing through both the greater and lesser sciatic foramen and pudendal vessel. Again, it is a right answer too. In this case, in such case where all more than one correct answer is present, I am preferring piriformis as it's the most prominent structure here, and as well as it's the structure that purely passes through greater sciatic foramen. But for the purpose of exam, usually you are given more clearer stems than this, and such mistakes usually occur due to the recall bias when you ask the participants about the questions they have attempted in the exam. So this is a list. I'm not going to go through them. If you want a detailed lecture, do contact us on these numbers or email. I will give you access to the complete lectures of the anatomy of the lower limb among the other lectures. And for the purpose, for now, you can take screenshot of the slide to memorize the structures that are passing through greater and lesser sciatic foramina. Gluteal region structures. If you palpate midway between the ischial tuberosity and greater trochanter, which structure will you be directly above? So this is technically a question from the surface anatomy. Between these 2 points, you are going to find the sciatic nerve. There is a greater trochanter, and here is the ischial tuberosity. And in between them, if you get between them, here you will find the sciatic nerve. So that is the point of the surface anatomy, and if you want to give a nerve block, you can access the nerve here, or you simply want to avoid the nerve, you can keep that in mind. Moreover, I would like to emphasize here that in the past paper questions, I have frequently seen superior gluteal vessels and nerves as the answer to this question. I would like to emphasize that that is the wrong answer. The superior gluteal artery and nerves are present 1/3 of the way between posterior superior iliac spine and greater trochanter. So keep that in mind and make your answer keys right. If your book says superior gluteal nerve as the answer to this question, as I have seen in a lot of books. A female patient is able to walk without any issues, but experience difficulty in standing up from the seated position due to the weakness in which muscle group? When talking about the hip joint, when you are standing up from a sitting position, hip is going to be extended. So you are going to find out which of the following muscles is extending the hip joint. Gluteus intermedius does not exist. Minimus and medius, okay, I'm not exist, or preferably the term that is used is gluteus medius. So gluteus medius and gluteus minimus, they are both abductor. Obturatus internus is lateral rotator and its abductor, and sartorius is a flexor. So we are only left with gluteus maximus, that is one of the chief extenders of the hip joint. So you are given a question regarding difficulty in standing from sitting position, and you are also given a question regarding waddling gait or tilting of pelvis, and that is due to the loss of gluteus medius and minimus. And for each of these questions, you should know the innervation of these muscles so that you can answer if the nerve is asked rather than the muscle. A patient experienced injuries from a road traffic accident and subsequently presented with the issues related to gait. During the examination, he was instructed to balance on the left leg, at which point the right pelvis is observed to tilt down. Which of the following structures is most likely to be injured? So, in the case of tilting of pelvis, it is due to the injury of gluteus medius and gluteus minimus. So, what happens is that if you are asked to stand on the left side, the gluteus medius and minimus muscle on the left side, they contract, they pull this end of the pelvic down, so the opposite end goes up. So in a normal person, when you are raising your right foot, the left gluteus medius and minimus contract, raising the pelvis on the right side, helping to clear the foot. That is the normal situation. However, in a person which paralysis of gluteus medius and minimus muscle, this does not occur. If a person raises the right foot, the support from the right leg vanishes. Support vanishes, and this was not working. So, under the effect of gravity, the pelvis will fall down on the side where the support had vanished. So, due to the paralysis of the gluteus medius and minimus on the left side, then due to the paralysis on the left side, the pelvis will tilt towards the right, and the vice versa will be true in the opposite side injury. This question can be this is known as positive Trendelenburg sign. Trendelenburg sign. So this is a positive Trendelenburg sign. You are asked question regarding that. It can be due to the gluteus medius or minimus paralysis. Its nerve injury, that is superior gluteal nerve. Its attachments avulsion, that will be avulsion of the greater trochanter. That is the attachment. That is the avulsion of the greater trochanter. And then there will be due to the neck of femur fracture, because the fulcrum against which this movement has been occurring uh, will be lost, neck of femur fracture. And last but not the least, hip dislocation. So in these two cases, the liver will not function, the fulcrum will be lost, and in these cases the muscles will be non-functional. So in all of these cases, Trendelenburg sign will be positive. A patient presents with a deep knife injury to the buttocks and exhibit waddling gait. This particular gait where the Trendelenburg sign is positive, and where when you lift a leg, that side of the pelvis tilt down, that is called waddling gait. It's also called waddling gait. It's Trendelenburg positive sign. It's dipping gait, where the pelvis tilts downwards on one side at each step. Which nerve has been injured? Now you should know the nerve of the gluteus medius and minimus, and that is the superior gluteal nerve. After a gunshot wound injury, After a gunshot wound, injury resulted in damage to the sciatic nerve. Which muscles is likely to be spared? In the hamstring aspect, all of the muscles are supplied except short head of biceps femoris. But here biceps femoris short head is not mentioned, long head is supplied by that, so it's okay. Gluteus maximus, it's not supplied by sciatic nerve, it is supplied by inferior gluteal nerve. Semimembranosus and tendinosus are supplied. So here is your answer. Moving on to the next topic, that is the thigh. Let us start with the anterior compartment. Which muscle functions as the flexor at both the hip and knee joint? I have seen that most frequently asked questions are about those muscles of the thigh that have the action on both the hip and the knee joint. That will be true for the sartorius, that will be true for rectus femoris, that will be true for the hamstring muscles. So keep that in mind. Which muscle function as the flexor at both the hip and knee joint? That muscle is sartorius muscle. It flexes both this muscle. Sartorius literal meaning is tailor. So imagine a tailor sitting on a ground with a crossed leg. So that is the function of the sartorius. When a person is sitting crossed leg on the floor, at the hip joint there is flexion. At the hip joint there is abduction. At the hip joint there is lateral rotation. At the knee joint there is flexion and there is medial rotation. So there is a lot of functions to remember for a single muscle, but to memorize you can just imagine a person sitting on a floor cross-legged. Try sitting it like that yourself and figure out at which position your leg and your hip and your knee joint is. Adductor longus, it's the adductor. Semimembranosus and tendinosus are extender of hip and flexor of knee. Identify the muscle responsible for hip flexion when the knee is in extended position. Try to imagine this position when you flex the knee, when you flex the hip joint and extend the knee, you are basically kicking. Imagine kicking a football and then your muscle is doing this way. So this muscle is also known as kicking muscle. The correct answer is rectus femoris. It runs from the front and it flexes the hip joint and extends the knee joint and you kick the muscle. You can be asked a question regarding which of the following muscle is activated during kicking of a football or is known as a kicking muscle. So the other muscles that you can think about here, you can revise the other muscles here, is the flexion at both hip and knee joint, that is sartorius. Hip is flexed, knee is extended, and in this case that is rectus femoris. Hip is extended, knee is flexed, that is the hamstring muscle, that will include semitendinosus, semimembranosus, and biceps femoris. And the flexion of the extension of the hip joint without knee, that is the adductor magnus, because it does not cross the knee joint. A high jumper has presented with a pain in the gluteal region. On examination, it is observed that is unable to flex the hip and extend the knee simultaneously. Again, the same question regarding rectus femoris. Which of the following injuries could be responsible for this condition? Now, you have not been asked straightforward regarding rectus femoris, rather than you have been asked about its attachment. Rectus femoris on its proximal end is attached to the anterior inferior iliac spine. So at this point is it attached to the anterior inferior iliac spine. So at this point it is damaged, so it is avulsed from it. Then the origin point, the loss of the origin point will render the muscle useless because it cannot pull the lower end up. Which is the root value of the femoral nerve? It is a frequently asked question. You should remember that femoral nerve is arising from L3, L2, L3 and L4, with L3 supporting the most content. And another question that is asked regarding the placement of this plexus, that is the lumbar plexus. This lumbar plexus is placed where? It is placed within the psoas major muscle. Another question is regarding which of the nerves of the lumbar plexus are exiting from which of the surfaces of that muscle. From the lateral aspect, you can see that it gives rise to iliohypogastric, ilioinguinal, lateral cutaneous. On the medial aspect, it gives rise to obturator and lumbosacral trunk. On the anterior aspect, you give rise to genitofemoral nerve. For each of the nerve, you should be ideally knowing the root values. We have frequently seen questions regarding the ilioinguinal, iliohypogastric, obturator nerve and lateral cutaneous nerve of thigh. I have seen the questions in past paper regarding these. Now, the femoral region, the femoral, technically femoral triangle region, In the femoral triangle, what is the arrangement of structures from medial to lateral? On the most medially, there is vein, then there is artery, then there is nerve. So you can use the mnemonic vein from medial to lateral: vein, artery, nerve. Which structure is located medial to the femoral hernia? The boundaries of the femoral ring from which the femoral hernia occurs is a very common question. Now this is the femoral ring. Anterior to it, I have written it here too. Anterior to it, there is inguinal ligament. Medial to it, there is lacunar ligament. Lateral to it, there is femoral vein, and posterior to it, there is pectinate ligament. So you can simply be asked about the relations to it. So what structure is present medial to it, lateral to it, anterior to it, posterior to it? And another question that is asked: to widen the femoral ring, the only safe wall is this, because it's a ligament that can be cut and the femoral ring can be widened due to it. Anteriorly, if you cut the inguinal ligament, the stability is gone. Posteriorly, you will have to cut the bone because pectinate ligament is running on the top of superior ramus of pubic. And the lateral aspect, the femoral vein cannot be cut because it will lead to the bleeding. During the repair of strangulated femoral hernia, which structure is at most risk of damage? You just saw on the medial aspect the femoral vein that is just adherent to it. You have to very carefully separate the hernia from the femoral vein because the injury of the vein will lead to profuse bleeding that can be life-threatening during the surgery. When repairing the femoral hernia, which vessel is most commonly at risk of injury? Here, interestingly enough, femoral vein is not given as an answer. There is external iliac, internal iliac, medial circumflex femoral, superficial epigastric. So here I would like to show you this picture. When femoral hernia occurs through the femoral ring, it goes down, it exits through the saphenous opening, and it moves up the thigh towards the anterior abdomen. And as it is moving up the thigh, here is the superficial epigastric vein, and in the similar pathway is the superficial epigastric artery. They are present just beneath in the superficial fascia where the hernial sac is present. So while mobilizing the hernial sac, if you are not careful, you can injure the vessels beneath that, and that can be injured too. That is a superficial epigastric artery in the case of the beginning of the surgery. At which of the following anatomical locations can a femoral pulse be palpated? Femoral pulse is palpated in the point that is midway between the anterior superior iliac spine here and the pubic tubercle. So in between them, this point just above it, about half an inch or so, there is the femoral artery that can be palpated, and that palpation is very important for the cannulation of the femoral artery, or most commonly cannulation of the femoral vein that is being done in the case of emergency dialysis when you have to vein a central venous catheter there. Where does a femoral hernia occur? So regarding the surface landmarks, the femoral hernia is present below and lateral to the pubic tubercle. Pubic tubercle is a very important landmark for differentiating between femoral and inguinal hernias. The femoral hernia is present below and lateral to the pubic tubercle, and the inguinal hernias, both the superficial and deep, they are present above and lateral somewhere here. They are present somewhere here. So they are present above and medial. I'm sorry for that. So above and medial is inguinal hernia, below and lateral is the femoral hernia. Moving on, the posterior aspect of thigh. Identify the muscle that is responsible for extending the hip joint while keeping the knee in the neutral position. So figure out the muscle that crosses the hip but does not cross the knee, and that is adductor magnus muscle that ends at the back of the femur only. Gracilis crosses both joints, but it is the adductor. Sartorius flexes the both joints. These two extends the hip joint but flexes the knee joint? So the correct answer is adductor magnus muscle. You can go through these to figure out the answer to the other commonly asked question in this scenario. Hip joint. Which muscle is primary flexor of the hip joint? For each joint, you are commonly asked questions regarding the type of the joint, like it's a ball and socket joint, and the muscles for the movement. Sometimes you are asked about the ligaments. The most commonly asked question regarding ligament is the strongest ligament of the body, iliofemoral ligament. But let us stick to the question at present here. Which muscle is primary flexor of the hip joint? The primary flexor is iliopsoas. Adductor magnus is the adductor. Sartorius is flexor, but it is a weak flexor as compared to iliopsoas, and gluteus medius is abductor. Which injury is most commonly associated with slippage of acetabulum and femoral head during traumatic incident? So they are simply asking the name of the situation where the femoral head is separated from the acetabulum. It is a very simple question that is known as dislocation of hip joint. Other questions are that's too easy a question. Fracture of tibia answer is given, artery, nerve, Achilles tendon, tear is given. Which of the following muscles is primarily responsible for abduction of the hip joint? Abduction of the hip joint is done by gluteus medius and gluteus minimus. So these are the abductor of the hip joint, and the loss of these functions, the loss of these muscles will lead to the dipping of the pelvis on the opposite side, especially when the leg is raised up. That is known as Trendelenburg sign. In the beginning of the video, we have discussed all of this. You can go back to that point to figure that out. Moving on to the next topic, that is popliteal fossa. You can be asked questions regarding its boundaries, regarding its contents, and one of the most common questions that is asked is which structure is the deepest located. A fracture of the knee or distal end of the femur may injure which deep structure located within the popliteal fossa. It is a very commonly asked question that which structure is present deepest in the contents of the popliteal fossa or most anteriorly. So that answer is popliteal artery. As very well you can see, the most anteriorly is popliteal artery, followed by vein and followed by nerve posteriorly or more superficially. Knee joint. This is one of those topics that you should do in entirety. You are asked question regarding its type, you are asked question regarding its bursa, you are asked question regarding the ligaments, at least the four major ligaments, that are the two collaterals and two cruciate ligaments. For a complete access of the knee joint lecture, please let us know on these numbers. We can enroll you in our lecture where the topic, the anatomy, is discussed in detail. Women who work with their knees bent may experience swelling and pain in the knee due to the inflammation of which structure? So a person who is cleaning the floor usually has knee placed against the hard ground. So at this point, the knee, there is the trauma right here between the patella and the hard floor below. So the bursa that is present in front of the patella, that is prepatellar bursa, that is most commonly inflamed, and that is known as housemaid's knee. That is known as housemaid's knee because the house help or housemaid spend a lot of time in this position when cleaning the floor, leading to the inflammation of the knee joint. To be more specific, inflammation of prepatellar bursa. Identify the structure that contains a tendon located within a joint cavity. This phrasing could have been more better. The knee, this can be you could have been asked that which of the following structure is present within the joint cavity of the knee joint. So there is only one muscle tendon that is present within the knee joint, that is the popliteus muscle, that is involved in unlocking of the knee joint. By the way, that is another question that is frequently asked. So this is the popliteus muscle. As it goes at this point it is entering the knee joint and it will go on to be attached to the lateral aspect of femur, and it will lead to the lateral rotation of femur on tibia, unlocking the knee joint. You are asked question about the popliteus in this way. Intracapsular, you are asked question regarding its function, that is the unlocking of knee joint, or you can be given the name of the muscle and then asked which movement does it produce. Which spinal segment is responsible for the myotomes that initiate knee extensions? By the way, you should be very fluent regarding the myotomes responsible for flexion and extension of the three major joints of lower limb: hip, knee, and ankle. And in the case of this, knee extension is brought upon by L3 and L4. L3 and L4. You can save this picture for later. At least these two, hip flexion and extension. At knee joint is the most frequently asked. Ankle joint is very commonly asked. The most frequently asked are knee extension and ankle plantar flexion, that is the ankle reflex. So these are the most commonly asked ones. You should be very much fluent with these. Others can be asked too, so keep this picture handy and memorize the hip, knee, ankle, and subtalar joint movements. Identify the meniscal structure associated with the medial aspect. There are four major ligaments in the knee joint: the anterior cruciate, posterior cruciate, medial, and lateral collateral ligament. Here there has been a mistake. Originally it should have been fibular collateral ligament. So let's keep it like this: anterior cruciate, fibular collateral, posterior cruciate, and tibial collateral. They can be alternatively asked as lateral or medial collateral ligaments. On the medial aspect, as the name indicates, is the tibial collateral ligament, and the association with the meniscus is that the medial collateral ligament, as you can see here, it is fused with the medial meniscus, as opposed to the lateral collateral ligament that has a distance or a gap with the lateral meniscus. By the way, in that gap, popliteus muscles tendon run. A 30-year-old male presents with a history of knee trauma after a fall. On examination, when examiner grabs the tibia and pulls it anteriorly, there is excessive forward movement of tibia relative to femur. Which of the ligament is most likely to be damaged? The answer is anterior cruciate ligament. So, for the anterior cruciate ligament, again, I will refer to my lecture. We have gone through the anatomy and mechanics in detail there. But for quick revision purpose, keep in mind that we try to memorize the cruciate ligaments with reference to tibia. If you can move tibia anteriorly on femur, like in this case where the femur is fixed and tibia is has been moved, so that is called anterior drawer sign. Anterior moving tibia, anterior drawer sign means anterior cruciate ligament. Posterior movement of tibia, posterior drawer sign means posterior cruciate ligament damage. The confusion occurs when you are not asked about the movement of tibia relative to femur. You are asked a question regarding the movement of femur relative to tibia. So I would suggest here to make up your mind with tibia, then reverse it. Let me give you an example. If you are thinking what movement become excessive after anterior cruciate ligament tear? Anterior cruciate means anterior movement of tibia on femur. In other words, it means posterior movement of femur on tibia. So that is a question that becomes difficult sometimes due to this loss of words, due to this difference between movement of tibia relative to femur or movement of femur relative to tibia. In case of anterior dislocation of femur, which ligament is most likely to be injured? Now, you are being asked about anterior dislocation of femur relative to tibia. Here I would suggest you to translate it in the opposite direction. That means This is equal to posterior movement of tibia relative to femur. When we are talking about movement of tibia, this gives the right answer. This means the injury is in posterior cruciate ligament. The injury is in posterior cruciate ligament. So here is the right answer. That is the drawer sign, posterior drawer sign, posterior. This question is asked in another way. If a person is moving down the stairs, your foot is planted on the ground, the tibia is fixed, then here the tibia is fixed. Due to the downward movement, the femur may move anteriorly due to the gravity, and that is made possible due to the loss of function of posterior cruciate ligament. So you can be ready for the question like that. A person cannot move down the stairs because whenever he does that, his knee dislocates, or whenever he does that, his femur displaces anteriorly with respect to the tibia. Then the injury is due to the posterior cruciate ligament. Moving on to the next region, that is the leg. Let us talk about the anterior compartment. The artery of the anterior compartment is deep. The artery of the anterior compartment, let me summarize it before. Anterior compartment, lateral compartment, and posterior compartment. You should know the artery, you should know the nerve, you should know the major function. Even if you don't know the muscles, you can answer most of the questions regarding that. That is the anterior tibial artery. Here the artery is peroneal artery. By the way, it is a very interesting situation that lateral compartment artery is actually present in posterior compartment that sends its branches to the lateral compartment. Posterior compartment contains posterior tibial artery. Then the nerve is that is the deep peroneal nerve, also known as deep fibular nerve. The lateral compartment contains superficial peroneal nerve, also known as fibular nerve, and the posterior compartment contains the tibial nerve. The anterior compartment is majorly responsible for dorsiflexion, and the most of the muscles are responsible for inversion except one, that is peroneus tertius. The lateral is responsible, majorly it's responsible for eversion, and minor function will be plantar flexion. And the posterior, its major function is plantar flexion. Then it has some, most of the muscles are also involved in inversion too. So take a screenshot, keep that in mind, and we will be solving the questions using this formula. Which artery is affected in the anterior tibial syndrome related to the musculofacial compartment? So the artery that is related to the anterior compartment is anterior tibial artery, and if that is affected, anterior compartment syndrome, that artery gets compressed and the supply of the anterior compartment and the dorsal of the foot is compromised. And you can figure it out by checking the pulse right here of the dorsalis pedis artery or here. A male athlete has sustained a fracture of the neck of the fibula. Which injury is most likely to occur? The artery that is most commonly injured in such a case is anterior tibial artery, as it moves from the popliteal fossa anteriorly between the tibia and fibula, and here it is running nearer to the neck of the fibula, leading to the break of the artery. Which muscle is responsible for the eversion of the foot? I saw that all of the muscles with the name peroneus or fibularis in them. So the lateral compartment containing the peroneus longus and brevis that is involved, the answer here will be peroneus longus muscle. A patient involved in the road traffic accident has sustained a fracture of the neck of the fibula and now is experiences an inability to perform foot eversion and dorsiflexion. Eversion is lost due to the lateral compartment. Dorsiflexion is lost due to the anterior compartment. So both the deep and superficial branches of common peroneal nerve have been damaged here. So the nerve that is most commonly injured here is the common peroneal nerve, as it supplies both the anterior and the lateral compartments. Regarding posterior compartment, the innervation question is a very frequent one and is asked in a variety of ways. Which nerve supplies the soleus muscle? All the muscles of the posterior compartment are supplied by tibial nerve. So soleus nerve, this muscle, the one that has been cut right here, that goes on to attach in the Achilles tendon, that is supplied by the soleus. It is responsible for the plantar flexion of your foot. In other terms, helping you standing on your toes. A patient is unable to perform plantar flexion. Which nerve is most likely to be damaged? That is again the tibial nerve. The MCQ could be asked to you in a way that a person is after an injury to the leg, he cannot stand on his toes to reach the upper shelf in his kitchen. Then this is due to the loss of tibial nerve or in the paralysis of soleus and gastrocnemius muscle. A patient presents with inability to plantar flex and invert the foot. Which nerve is most likely to be damaged? Again the answer is tibial nerve. Here, in addition to the plantar flexion done by soleus and gastrocnemius, the inversion has been added. The inversion is done by the tibialis posterior and these muscles, the tibialis posterior muscle right here and the flexor hallucis muscle and the flexor digitorum muscle. All of these muscles are responsible for inversion of the foot too. In the case of congenital absence of dorsalis pedis artery, that is the artery that is the continuation of the anterior tibial artery, which supplies the dorsal aspect of the foot and supplements the deep plantar arch. If that is congenitally absent, which artery is responsible for supplying that region? If that is congenitally absent, the peroneal artery supplying the lateral compartment gives a large branch that gives rise to the branches or vessels that are supplying the dorsal aspect. Let us talk about the ankle. Very common questions regarding ankle are the shape of the joint and the muscles providing the movement. We talked about that already in the leg regarding the muscles of dorsiflexion and plantar flexion, and then we are left with the two major ligaments. On the medial aspect there is deltoid, on the lateral aspect there is lateral ligament. It is further divided into three parts. The herniated disc can lead to the absence of ankle reflex. Which of the root value is associated with it? I told you already to keep in mind the root values of the movement of three major joints, especially knee and ankle joint. So for the ankle reflex, that is plantar flexion is being done here, S1 and S2. So the injury must has been between these among these two nerves. For the major reflexes, for the biceps reflex in upper limb, for the triceps reflex, for the brachioradialis reflex, for knee reflex, for the ankle reflex and the superficial abdominal reflexes, you should know the root values. And for the head and neck region, you should know the nerves involved in the corneal, pupillary, jaw jerk and these superficial reflexes, very commonly asked in your exams. A child playing outside suffers an ankle sprain. Which structure is most likely to be injured? So actual injury depends upon whether the foot has been over inverted or everted. That situation has been not given in this question. So try to think about your experiences. In which direction does your foot turns most commonly when such an event occurs? Especially ladies who wear high heels can answer this question a little better, that your foot is usually inverted in case of slipping. If the foot is inverted, then the outward direction there it is lateral ligament that is damaged. So the lateral malleolus itself may be avulsed if the ligament remains itself intact. So it may break the lateral malleolus from the fibula bone. Then the answer can be asked regarding the lateral ligament and the three parts of the lateral ligament, that includes the ligaments, that is anterior, posterior, talofibular ligaments and calcaneofibular ligaments. Let us start with the MCQs of the foot region. In the foot, a worker sustains an injury when a piece of wood landed on the top of the foot, especially between the first and the second metatarsal bones. Which artery is most likely to be injured? We saw that briefly in the leg region too, that the artery that is running on the dorsal aspect of the foot between the two malleoli is dorsalis pedis artery. So that is the dorsalis pedis artery. So that is injured when there is an injury between the first two metatarsal bones. That question is asked in a variety of ways. The artery present between the two malleoli, the artery accompanying the extensor hallucis longus tendon, and a number of ways too. So keep in mind that question is very important. The deep plantar artery is a branch of which artery? Again, the dorsalis pedis arteries. As this artery from the between the first two toes, it dips down to the plantar aspect. It then goes on to run right here on the plantar aspect. It will make the deep plantar artery. So dorsalis pedis artery is the major supplier of this arch. A patient presents with a heavy bleeding following an injury between the base of the first and second toe. Which artery is most likely involved? Again, the dorsalis pedis artery, the space between these two toes. Injury to the adductor hallucis muscle is associated with which artery? Again, the answer is the dorsalis pedis artery, because as you see, as it runs between the two metatarsal bones to go to the plantar aspect of the foot, it runs between the first dorsal interosseous and between the two heads of the adductor hallucis muscle. So that question can be asked to you directly to that dorsalis pedis artery while going to the plantar aspect of the foot to make the plantar arch, it runs between the two heads of, that answer will be adductor hallucis. A 32 years old carpenter falls from a roof, fracturing the keystone bones of the lateral longitudinal arch of the foot. Which of the following bones is most likely to be fractured? A commonly asked question is regarding the keystones of the lateral and medial arches. More commonly about the medial arch, but here the lateral arch has been asked. The lateral arch keystone is the cuboid bone. That is the bone that is on the top of the arch that hold of the arch. If that bone is plucked out, the whole of the arch will collapse. In the case of the medial arch, the talus is the one that is wedged in to form the capstone or keystone. The medial arch of the foot is supported by which of the following ligaments? If you follow the medial arch and you can see this ligament, so medial arch will include calcaneum bone, the talus, the navicular, the three cuneiforms, medial, and then the metatarsal, the three metatarsals. So this ligament is very crucial to it, that is known as the plantar calcaneal ligament, and that is also known as spring ligament, that holds, that gives a strong attachment between sustentaculum tali of the calcaneum and the navicular bone, holding them together, giving a resting space for the talus above. So that is it. The deltoid ligament is the medial ligament. That is actually a correct answer to both of these are the correct answer. No answer is better than the others. Both of them are correct answers here. Ideally speaking, only one of them should be present. Regarding superficial structures, there are four structures that you need to keep in mind: the great saphenous, the small saphenous, and the nerves accompanying. The great saphenous accompanied by saphenous vein, the small saphenous accompanied by a sural nerve, and then there are lymphatics. The great saphenous, the nerves accompanying great saphenous from the toe side, from the medial side, goes to the superficial inguinal, and the vessels, nerve vessels accompanying the small saphenous on the lateral aspect, lateral side, little toe side, they go to the popliteal nose. So on these 3 points, all of the questions you will follow. The patient who has experienced trauma and work had presented with inability to locate a vein from the cannulation of the upper limb. Which nerve would most likely to be appropriate for IV access to the lower limb? So a very commonly used nerve is great saphenous vein. Why? Because it's one of the largest superficial veins of the body. and secondly it has a very constant position in front of the medial malleolus. For a hypovolemic person where you cannot find the veins, you just blindly prick in front of the medial malleolus, and more often than not you find the great saphenous vein, and if you're not able to do that, you do venous cut down to get an access. So great saphenous vein is very commonly accessed when in the case of difficult cannulation. During coronary bypass surgery in heart bypass or CABG, which of the following vein is most likely used as a graft? The great saphenous vein, due to its accessibility and due to its sheer large size, it is used as the bypass grafting vein. And due to excessive anastomosis in the leg, the absence of the great saphenous vein can be compensated by the collateral circulations. And there in the thorax it is inverted, reversed, so that the valves does not impede the pathway. The great saphenous vein is most commonly approached for the procedure at the anatomical site. We just saw that great saphenous vein, it started from the dorsal venous arch in front of the medial malleolus, anterior to the medial malleolus. It's a very important point of view from an exam point of view, from your clinical practice point of view. It passes anterior to the medial malleolus where it is approached. So that landmark is very commonly used for cannulation and for venous cut downs. The lateral part of the foot is damaged during drill exercises in the armor cadet, which is the lymphatic drainage of this region. On the lateral aspect, the vein is the small saphenous, and the lymphatics follow the small saphenous to go to the popliteal nodes. From the lateral aspect, there is small saphenous, and by the way, small saphenous runs behind the lateral malleolus, and it runs on the posterior aspect of the leg until it reaches the lymph nodes right here, and these are present in the popliteus fossa. These are the popliteal nodes. A patient presents with a groin pain and infection of the big toe. Which of the lymph node is most likely to be involved in the spread of infection? When the big toe is infected, from the big toe aspect, from the medial aspect, the vessels that will, the lymphatics that will be followed are going along the great saphenous vein, and they are going to the vertical group of the superficial nodes. They will follow all this way until they reach here, and there is the vertical group of the superficial inguinal nodes that are receiving that. So the lateral aspect is going to the popliteal node, and through that it is going to the deeper structure and bypassing the superficial inguinal nodes. Superficial nerves. The patient undergoes venesection. Venesection is done at the great saphenous anterior to the medial malleolus. Which nerve is most at the risk of potential damage? The nerve accompanying that vein is the great saphenous vein, is the saphenous nerve. It is actually a branch of the femoral nerve. That is again another question that is asked. That is a branch of the femoral nerve, and that goes here, it exits right here and goes all the way to supply the medial aspect of leg and the medial aspect of foot too. A patient sustains an injury on the inner aspect of knee, resulting in loss of feeling on the inner side of leg and foot. Which of the nerve is likely to be affected due to damage? Again, the same answer, the saphenous nerve will be most likely damaged. Here you can see femoral nerve is involved too, but whenever you are given two options, then you give the answer of the vessel or a nerve or a lymphatic that is nearer to the target. Like saphenous nerve would be more accurate answer as compared to the femoral nerve. In absence of the saphenous nerve, femoral nerve would be opted. A patient sustains an injury to the medial aspect of knee, resulting in diminished sensation on medial aspect of leg and foot. Again, the same question, same answer, saphenous nerve. Small saphenous vein is accompanied by which nerve? The small saphenous vein is accompanied by sural nerve. As you can see, this is the sural nerve. It is a branch of the common peroneal and tibial nerve both, and it accompanies and supplies the posterior aspect of leg. The medial plantar side of the foot is innervated by which of the following nerve? If you see the sole of the foot, it is supplied by the medial plantar nerve and lateral plantar nerve. Both of these are branches of tibial nerve. So tibial nerve has been given, the medial plantar nerve and lateral plantar nerve, even medial calcaneal nerve. The whole of the sole of the foot is supplied by tibial nerve, and that will be your correct answer here. Which nerve supplies the lateral aspect and dorsal surface of the foot? Where lateral aspect of leg can be a better word. Lateral aspect of leg and dorsum of the foot is supplied by common peroneal nerve to be more accurate, but lateral aspect of leg is not given, and the only option, the near to the correct answer is deep peroneal nerve. That is the correct answer here. Ideally the answer should have been common peroneal, but that is not given. None of the other is responsible for lateral aspect and anterior aspect. The sural nerve is supplying the back, the saphenous the medial aspect, and the tibial nerve supplying the plantar aspect of the foot. Loss of sensation in the anterior thigh can result in which of the from injury of which of the following nerves? The anterior of the thigh for most of the aspect is supplied by femoral nerve. From the these are the lateral cutaneous, intermediate cutaneous, and medial cutaneous branches of the anterior thigh. The intermediate and medial cutaneous branches of the thigh are branches of the femoral nerve. This is an independent branch from the lumbar plexus. So here the femoral nerve will be damaged. So this part is supplied by obturator nerve, and this is again by the saphenous nerve, that is a branch of femoral nerve. Thank you so much for listening to the questions. I hope that have been more useful. If you have any further suggestion and any questions, please mention in the comments. Before I close up, I would like to show you another thing. If you like to stay in contact with us and see more of our content, do subscribe to us and join our page. Let me add here. Okay. Do connect to us on our Facebook page by the name of Medicos Academics. You will find our course. We run a course on preparation of FCPS part 1, where we discuss subject wise, give answers, discuss questions, and as you can see, you can join our course. We will join us to our learning management system, where all of we go through the whole course, 2.5 months. We go through in a schematic way, discussing the questions, topics, like this. You can see you have cell nerve, muscle physiology, pathology, upper limb, lower limb. That has been followed by a test. You can go ahead, attempt the test, and test yourself before moving forward. You can have so many questions, and we will continuously we're adding more and more questions to our LMS. And on that point, another thing that we have added free of charge is our new platform, that is MedEd. We have launched an application available on iOS and available on Android, and you can access it on your browser using app.meded.pk. You can attempt all the questions subject wise. You can find the question papers by exam, like surgery and allied to August 2023 afternoon question paper. You can answer that. And the thing that is my most favorite is you can build your own question paper to test yourself. You want to test yourself regarding pathology, pick a pathology, and then pick a topic like general pathology that you want to go through, and you have 140 questions there, and then go ahead and keep attempting the MCQs. That system gives you an instant feedback, and we are continuously adding more and more questions from different attempts, and we are very welcoming people, and we welcome you all to join, to test our system, to give us feedback, and to tell us anything you can about how we can improve our system. So thank you so much for listening, for giving time. If you have any questions, suggestion, and feedback, please let us know. Till the next time, Allah Hafiz.